This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Welcome back. In our last lecture, we covered some very general information about strokes, including the different types of stroke, the symptoms and deficits associated with a stroke, and how to diagnose and treat a stroke. Today, we're going to discuss risk factors for stroke, the types of aphasia that most commonly occur following a stroke, what we know about spatial neglect, and finally, a little about the strange condition known as alien hand syndrome. Before we get started, though, I want to share some personal information that may surprise you. As I was writing this very lecture, I myself suffered an aneurysm. In April of 2021, as I was working on this lecture, my doctor ordered some routine blood work for me. He requested that I come to see him at his office to go over my results. At the appointment, which showed that my blood work was fine, we talked about my triathlon training. I happened to mention that every so often, I experience these small, short bursts of dizziness. The doctor said he would like me to have a computed tomography angiography, or CTA scan. He then told me that he had also experienced dizzy spells once, and it turned out he'd had an unruptured aneurysm in his brain. I had the CTA scan about 2 weeks after my appointment on April 9th, 2021. I'll never forget that night because my doctor called to tell me that I had an unruptured brain aneurysm. I was in complete shock. And then my anxiety shot through the roof. I didn't sleep or eat much that weekend, and I Googled information like crazy, which was sometimes good and sometimes bad. About 1 out of 50 people have a brain aneurysm. These types of aneurysm are generally asymptomatic until they burst and a subarachnoid hemorrhage occurs. People usually don't know they have an aneurysm. They are typically found incidentally, like mine. Sometimes these types of aneurysms run in families, but to be considered hereditary, there needs to be evidence of at least 2 family members having had a subarachnoid hemorrhage. This was not true in my case. Doctors didn't know how long I had the aneurysm or when I developed it, although research suggests they are most common in women over the age of 40. I immediately needed to stop swimming, biking, and running until I could be evaluated by a neurovascular surgeon. At the time, I didn't know how large my aneurysm was, whether it would rupture or not, and whether or not I would need surgery to treat it. Though not all aneurysms rupture, research currently can't predict which ones are likely to and which ones are not. Interestingly, I found out after the fact that dizziness is not even a documented symptom of an aneurysm. So it's really fortuitous that mine was discovered at all. But boy, am I glad it was. 2 weeks after I received my diagnosis, a neurovascular surgeon at Tufts Medical Center in Boston performed an angiogram on me. He needed to do this to examine the specific characteristics of my aneurysm and determine the best treatment approach. There were 3 potential treatment options. Do nothing but monitor the aneurysm over time, which is risky because we don't know what makes an aneurysm likely to burst. Clipping, where doctors would need to go through my skull, and endovascular surgery, which involves web devices, coils, and/or stents. Here, the brain is accessed through the femoral artery in the groin. For the angiogram, I was mildly sedated but fully conscious. My head was taped down so I wouldn't move it. Once I was administered a local anesthetic, the surgeon inserted a catheter with a small camera on the end of it into the femoral artery in my groin. The doctor then threaded the catheter all the way up to the top of my neck in the internal carotid artery. Then he asked me to hold my breath a few times, at which point contrast was released into my arteries and pictures were taken. I could feel the contrast being released as it created very warm sensations in different parts of my face, which felt very strange. The weirdest was when I felt warm sensations in my eyeballs. After all the pictures were taken, the catheter was removed and the surgeon pressed on my femoral artery for 10 minutes to promote clotting. I then had to lie flat for 4 hours and was not permitted to bend my leg or lift my head. This proved to be challenging, especially because my back started to hurt after a while. That day, I experienced a headache and some soreness where the catheter was inserted, but was otherwise fine. Following the angiogram, the surgeon told me that he could do an endovascular procedure, a serious relief, as I really didn't want them to go through my skull. I'm now going to show you 3 pictures. In the first picture, you can see where the circle of Willis is located. It is on the underside of the brain between the 2 temporal lobes. On the left, you can see a blown up version of the circle of Willis, and you can see where my aneurysm is located, at the bifurcation point of the internal carotid artery. The second picture is an actual image taken from my angiogram. I've circled the aneurysm. It is saccular, which means berry-like. The third picture shows the endovascular procedure I had done. My surgery was scheduled for a week after the angiogram. I was going to be in the hospital for 2 nights and then would need to rest for an additional 4 to 7 days. On May 6, 2021, I arrived at the hospital at 9:30 a.m. to check in for surgery. I was taken back to the pre-surgery area to change into a hospital gown, have an IV inserted, and meet with my anesthesiologist. At 11 a.m., I was wheeled down into the operating room and given general anesthesia. Following the surgery, I learned that my doctor used a coil on my aneurysm. He tried a web device, but wasn't satisfied with how it fit, so he went with the coil. No stents were needed, which was great news, as it meant I didn't need to be on blood thinners. I'm not going to lie, the next couple of days at the hospital were rough. I had headaches and also some nausea and vomiting. They kept me an extra day at the hospital to make sure I didn't have any type of bleeding in my brain, which was confirmed by a CT scan. I was released on Mother's Day and did very well once at home. All my headaches subsided and I had no nausea. I was just tired. One thing I did do was go online to the patient portal and read my MRI and CT scan reports. These reports mentioned lesions in my brain that had not been there before. Well, of course, this freaked me out, so I called my PCP and neurosurgeon. They both assured me that the lesions are a consequence of manipulating the arteries in the brain and that they resolve themselves with time. Phew. Let's now move on to talk about risk factors for stroke, which can be divided into 2 categories: unmodifiable and modifiable. Unmodifiable risk factors are those that nobody can control. They include age, gender, race or ethnicity, and family history. Stroke risk increases as you get older, and it's more common in men than women, although women are more likely to have them when they're older and to die from them. Research also shows that African Americans and Hispanic Americans have double the stroke risk than Caucasians and tend to have them at younger ages. Now let's discuss modifiable risk factors, those that we can control, starting with high blood pressure, which is the #1 risk factor for stroke. In fact, before the age of 80, the risk of stroke among those with high blood pressure is 2 to 4 times higher than in those without it. This is because high blood pressure promotes atherosclerosis and causes damage to blood vessels. Normal blood pressure is 120/80. Once you go over these values, you start entering various stages of hypertension. Stage 2 hypertension is defined as a value of 140/90. Genetics plays a role in high blood pressure. High cholesterol also increases stroke risk. In general, low-density lipoprotein, or LDL, the bad cholesterol, should be less than 130 milligrams per deciliter of blood. LDL levels between 130 and 159 give you a slightly higher risk for atherosclerosis, heart disease, and stroke, and values greater than 160 are associated with the greatest risk for heart attack or stroke. High-density lipoprotein, or HDL, the good cholesterol, should be greater than 35 milligrams per deciliter of blood. Levels under 35 increase the risk for heart attack or stroke. Genetics play a role in high cholesterol values as well. Smoking tobacco doubles the risk of having a stroke by promoting atherosclerosis and aneurysm formation. It also stimulates blood clotting factors. Risk significantly decreases 2 years after quitting, and by 5 years, the risk is comparable to that of non-smokers. Diabetes can damage blood vessels in the brain and increase the risk for stroke. In people with diabetes, glucose or blood sugar does not move efficiently from the blood to the body's cells. Instead, it builds up in the blood, which can cause damage to the blood vessels. Genetics can play a role in the development of diabetes. Short-term and long-term use of addictive drugs like cocaine and amphetamines, as well as excessive alcohol consumption, can damage blood vessel walls, causing them to rupture and bleed into the brain. Drugs and alcohol can also narrow the brain's blood vessels and stop blood flow, causing an ischemic stroke. An irregular heartbeat can cause blood clots to form in the heart that can loosen and travel to the brain. Blood thinners can help reduce one's risk. Carotid and other artery diseases occur when fatty deposits clog vessels that deliver blood to the brain and head. This condition develops slowly and results in a narrowing of the arteries, which can lead to stroke. Finally, obesity is a risk factor for stroke due to its association with high blood pressure, diabetes, and heart disease. So, if you have high blood pressure or cholesterol, do what you can to lower it. Ask your doctor if you have an irregular heartbeat, also known as atrial fibrillation. If you smoke, do everything you can to stop. I know, easier said than done. Drink alcohol in moderation. Control your diabetes if you have it. Exercise daily, and cut down on your intake of sodium, saturated fat, and trans fat. Now that we've talked about risk factors, let's turn our attention to some of the conditions that can arise from stroke, starting with aphasia. The word aphasia basically means a language disorder that affects an individual's ability to communicate. 3 of the most common types of aphasia following a stroke are Broca's aphasia, Wernicke's aphasia, and global aphasia. Broca's aphasia can occur when an area in the frontal lobes, generally on the left side of the brain for most people, is damaged. Symptoms include non-fluent speech, halting with many pauses between words, signs of anomia, so word-finding difficulty, mispronunciations, for example, saying Reich instead of right, agrammatic speech, so speech that contains nouns and verbs but lacks adjectives, adverbs, or conjunctions, omitting small words like is and the, and writing that appears to be disjointed. Vocalization is not lost with Broca's aphasia, though. People with Broca's can recite familiar information, like the days of the week or the alphabet, and they can sing familiar songs. Rather, what is impaired is the ability to translate thoughts into speech patterns. Here's an example. Let's say you've got Broca's aphasia and you're going to the hospital on Monday for dental surgery. When you try to relay this fact to a friend, you know what you want to say, but you have to actually translate your thoughts into real spoken words. The thoughts inside your head will sound fine and fluent, but when you actually try to speak them, your words will sound halted and broken, like this. Yes, Monday, dad, hospital, and Wednesday, 9 o'clock, and Thursday, 10 o'clock, doctors, 2, doctors, and teeth. Individuals with Broca's aphasia are aware that what they think inside their head and what they actually say do not match, which can make them extremely frustrated and even depressed. So how is it that those affected can still easily recite days of the week in the alphabet and can sing familiar songs? Well, all 3 of these are things you memorize. When you hear your favorite song being played, you might automatically just start singing along without having to think about it. It's effortless for you. Rather than translating thoughts into speech, you are pulling up information from memory and reciting it. This is where the difference lies. What's interesting and somewhat bizarre is that this also happens with curse words. A Broca's patient may have a lot of difficulty speaking, but cuss just fine. Scientists speculate that this is because cursing falls into the same category as singing along to a favorite song. It is an automatic reaction, in this case to anger or frustration. They also believe that these specific categories of language are more a function of the right hemisphere than the left, which is why they are not impaired with damage to Broca's area. Luckily, even though their speech is impaired, patients can still comprehend language quite well. In contrast to Broca's aphasia, Wernicke's aphasia usually results from damage to the left posterior temporal lobe area. The main symptom is meaningless speech, often referred to as a word salad. So the person talks fluently, with a normal rate, rhythm, and grammar, but it doesn't make any sense. What's more, patients are unaware that their words can't be understood. They also have trouble understanding what others are saying to them, and their writing and reading skills are also impaired. Consider this example. Let's say you've got Wernicke's aphasia, and you want to say that you're taking the dog out for a walk. Instead, the words might come out like this. You know that Smoodle pinkered and that I want to get him round and take care of him like you want before? It sounds articulate and smooth, but it makes no sense at all. Unlike Broca's aphasia, those with Wernicke's aphasia do not tend to have depression or emotional outbursts. Makes sense though, right? Because they are not aware of their deficits, they wouldn't get upset about them. Finally, global aphasia is caused by extensive damage to language areas in the brain. Think of it as having both Broca's aphasia and Wernicke's aphasia at the same time. Both spoken and written language are severely affected. Let's now talk a little bit more about spatial neglect, which we covered briefly in Lecture 1. This is one of the conditions my mom developed following her stroke. To refresh your memory, spatial neglect is typically caused by damage to the right hemisphere. Lesions in patients with the condition tend to be large and usually involve 2 or more cortical or subcortical brain areas, the most common being the posterior parietal lobe, superior temporal gyrus, medial temporal lobe, frontal lobe, and the basal ganglia. Neglect is typically caused by an ischemic stroke occurring in the middle cerebral artery. Remember that in spatial neglect, a person only attends to things that are in their right visual field, ignoring anything in their left visual field as if it weren't there. Patients may only eat food on the right side of their plate, like my mom did, or they may pay less attention to their left side when grooming, such as by shaving or applying makeup to only one side of their face. They also may neglect the limbs on their left, which can result in obvious difficulties with physical rehabilitation. Interestingly, an individual patient's degree of neglect can fluctuate even within the same day. This depends upon overall arousal, which is known to be affected by a right hemispheric stroke. Patients with spatial neglect also often fail to complete the left side of drawings they are asked to copy. They miss the words on the left side of the page when reading, ignore people standing to their left, and collide with the wall on the left when walking down a hallway. Many of these deficits can be picked up through standard neuropsychological testing. One easy way to pick up neglect is to use a test known as line bisection. Here, a patient is shown a horizontal line and is asked to draw a vertical line through its center. What do you think happens when a person with spatial neglect is asked to do this? That's right. They end up drawing a line to the right of the horizontal line's center. One thing I find fascinating about neglect is that patients have it not just for real visual scenes, but also for mental imagery. So, for example, if I asked a neglect patient to form a mental picture of their bedroom and to describe it to me, more than likely, they will omit objects falling in their left visual field in their imagined mental image. This supports the notion that the right hemisphere plays a role in visual representation of both real space and imagined space. The next condition we'll discuss here is perhaps the strangest of them all, alien hand syndrome. Patients with this disorder perceive their limb, usually their hand, as foreign, and the limb performs autonomous complex movements against the patient's will. Some patients even deny ownership of the limb, going so far as to give it names, usually negative ones, like the devil. One typical sign of alien hand syndrome is intermanual conflict, where one hand acts at cross purposes with the other. So, for example, a patient might try to put on clothing with their right hand, while at the same time their left hand is trying to pull the clothing off. Yeah, it's strange. One hand might try to turn the pages of a book, while the other hand tries to close the book. One person with alien hand syndrome claimed that she would try to light a cigarette with her right hand, while her left hand would remove the cigarette from her mouth. Another said that his left hand would make moves in a game of checkers that he then had to correct with his right hand. Another sign is mirror movements, where one hand mimics the movements of the other hand. So if the person tries to answer the phone or pick up an apple, the other hand mimics the exact movement. There is also a sign called enabling synkinesis, where one hand can only perform actions in unison with the other hand. Then we have the grasp reflex and impulsive groping of objects. Here, a patient will grope for and grasp any object that's nearby. If they were to sit across from somebody's office desk, their alien hand would likely be reaching for and grabbing any and all objects on that desk. Some patients even claim that the alien hand grabs their own throats while they're sleeping. They have to tie their arm down so that their hand doesn't try to kill them as they slumber. I swear I am not making this up. I mean, can you even imagine going to bed at night worried that your own hand might try to strangle you while you sleep? Some patients also claim that their alien hand is highly reactive to verbal suggestion and will perform acts mentioned in casual conversation. Finally, we have compulsive manipulation of tools. Here, the hand uses tools impulsively. Imagine a patient trying to hammer a nail into a board sitting on top of a table. The alien hand will compulsively try to hammer the nail over and over again while the other hand moves the board. The patient feels compelled to use the hammer and cannot stop the action, even though it is not productive. Patients can develop alien hand syndrome from damage to one of three primary areas: the anterior regions of the corpus callosum, the medial frontal cortex, or areas of the brain associated with the posterior cerebral artery. The brain damage typically occurs as a result of a stroke, both ischemic and hemorrhagic types, or from surgical intervention, typically a commiserotomy for epilepsy. Damage to anterior regions of the corpus callosum typically results in alien hand signs of intermanual conflict, mirror movements, and enabling synkinesis. Damage to the medial frontal cortex generally involves the premotor and supplementary motor areas and the anterior cingulate cortex, resulting in the grasp reflex, impulsive groping, and the compulsive manipulation of tools. Finally, damage to the posterior cerebral artery typically results in signs such as arm levitation and other non-purposeful movements, including groping. It really does sound like something you might see in a horror film, doesn't it? Thankfully, for some patients, symptoms of alien hand syndrome can diminish with time, though they rarely fully disappear. As the past two lectures have shown, the symptoms of stroke are wide-ranging and can have a serious impact on quality of life. While we can't prevent strokes from happening entirely, we do know that there are steps we can take, like lowering blood pressure, to reduce our risk. Thanks for listening, and join us next time for the first in another 2-lecture set, this time on Alzheimer's disease. Bye for now.